from Abasa, Dr. Arena, and their colleagues. Thank you also, Samantha, for introducing my topic of emergency surgeries. So today we're going to take a look at the state of the art. What are we considering nowadays with patients for perioperative monitoring? I took two examples, which are the ACS and skip score and the revised cardiac risk index that, of course, all of you know, to show that some of them, even the more famous, have some limitations. For example, the ACS and skip score, as you all know, is more a surgical predictor rather than cardiovascular. So in our case, it's not so useful. The revised cardiac risk index, which divides patients into 4 classes of risk, is very useful and very used also in the cardiology setting preoperatively. But there are increasing studies that show that it's not sufficient alone to direct the postoperative monitoring of the patients. What's more, our population is a particular population, so emergency surgeries are not really so predictable like the elective ones. So what are our questions? Our questions are, can we imagine that the patients undergoing emergency surgeries unfortunately suffer from more MACEs and for more mortality than elective surgeries? And if so, can we say which patients should be closely monitored after surgery? And are we able to identify a specific surgical discipline or more that have a higher rate of MACE and mortality in emergency setting? So we examined 7 surgical disciplines, which are orthopedics, spinal surgery, thorax surgery, trauma surgery, urology, vascular surgery, and visceral surgery. I'm taking advantage of the former presentations and not presenting the inclusion criteria here, but we used the PMI cohort of patients, in my case from Basel, Arau, and São Paulo in Brazil. 355 were excluded, and then we had 7,500 patients undergoing elective surgeries and 2,850 patients undergoing emergency surgeries. Today we are going to focus on the emergency surgeries which were carried out within 24 hours because we divided the population also into urgent surgeries between 2 and 7 days after indication. Our patients underwent follow-up for 1 year, and our primary endpoints were all-cause mortality, both at 30 days and 1 year, and MACEs, which are a composite of acute heart failure, acute myocardial infarction, arrhythmias, and cardiovascular death, both at 30 days and 1 year. But today we are going to focus on the 30 days outcomes. Here you can see in the baseline characteristics, also like my colleagues before showed, that we can notice in gray overall population, in blue populations who didn't suffer a MACE, and in red those who suffered a MACE. As you can see, the patients who suffered a MACE are a little bit older than their colleagues who didn't, so 75 years in the no MACE population and 78 in the MACE populations. They had coronary heart disease more than the no MACE population, previous myocardial infarction, congestive heart failure, atrial fibrillation, peripheral heart disease, diabetes, COPD, and also chronic kidney failure, and they took more medications regularly for their comorbidities. We then proceeded to examine the incidence of mortality and MACE. This is at 30 days, as said. In red, you will find the MACEs, and in pink, you will find all-cause mortality. As you can see, all of the surgical disciplines are under the 10% of those of incidence, except thoracic surgery, which is a little bit higher in both. So it's 32% in MACEs and 38% in mortality, and vascular surgery, which is slightly higher in mortality at about 12% of the patients. Then we conducted a multivariate Cox regression analysis with which was adjusted for age and sex. As you can see here, for the MACEs at 30 days, thoracic surgery is well above the other curves with an hazard ratio of 22. And the same can be said in the mortality curve, which is all-cause mortality, in which we can also notice vascular surgery, which is significant with an 8.4 hazard ratio. We can say that, so nowadays we don't have a validated tool or score to monitor these patients. The incidence of complication, we can say, in this population was acceptable in almost all of the surgical disciplines. An exception is, of course, thoracic surgery and vascular surgery. What could be a limitation is that, of course, the number of emergency surgeries in the thoracic field were a little smaller in comparison to the other categories. Thank you very much for your attention.
Thank you very much for the great talk. Are there any questions from the audience? Yes, please.
Payman Nazirian from the Emergency Department, Careggi University Hospital here in Florence. I would like to ask which kind of thoracic surgery are you considering? Is not trauma thoracic surgery, is it included in trauma or in?
It's included in trauma surgery. In thoracic surgery, most of the patients had an emergency surgery due to two different diseases, if we can divide them, pleural emphysema and hemothorax. Hemothorax was due not to trauma, but spontaneous due to pulmonary tumors, or a consequence of a first pulmonary intervention before. So it was a second surgery. But it was divided in this way, so trauma populations are in the trauma surgery.
Thank you.
You're welcome.
Any other questions?
Thank you.